Good morning, everyone. Good afternoon. Welcome to the GBV AoR Community of Practice webinar series. Today, we're very happy to invite you to learn more about remote GBV services that focus on phone-based case management and hotlines. As you can see from the slide, there's a number of partners that have been involved in putting this together. And before we get into it, I wanted to tell you a little bit more about the GBV AoR Community of Practice for those of you who are not familiar with it. Let me get this first. So the GBV AoR Community of Practice is a product of the GBV, gender-based violence, area of responsibility. We're a community of over 1,000 gender-based violence and emergency specialists all over the world. We are very focused on providing peer support, peer-to-peer support, sharing resources, and developing things like this webinar for gender-based violence and emergency specialists. If you want to join, if you're interested in finding out more about it, you can always send us a message to gbvcop@gmail.com. Another product of the GBV AoR is the help desk. So if you need some support or some help, you can always contact the GBV AoR Helpdesk. They provide literature and evidence reviews, evidence digest, they produce guidance notes. You can have up to 3 days of support and help from a gender-based violence specialist who will do a phone call with you, help you, and talk you through your needs. So if you have any questions and you want to access this, again, it's free and available one-to-one support for your gender-based violence needs. You can email at inquiries@gbviehelpdesk.org.uk. And of course, you can always go to the GBV AoR website and get more information on the help desk or on the community of practice. So that's who we are at the community of practice. So today, we're going to be hearing from a number of different people, and we're going to be looking at the phone-based case management. So without further ado, I'm going to be quiet and turn it over to Kara Mosmungi from UNICEF.
Thank you so much, Sarah, and thanks everyone for being here. We're very excited to introduce you this resource on remote case management training package. So just to give you a little bit of background and maybe to introduce myself first, my name is Caroline Mosmungi and I work with UNICEF in our gender-based violence in emergency team. I oversee our portfolio on service delivery and innovation. And I've been part of this journey around remote case management from the beginning of COVID-19. So I just wanted to give you a little bit of background on this. When COVID hit, we, like a lot of service providers, reached out to us. Obviously, as UNICEF, our country offices and partners, but also as UNICEF is also a member of the GBV IMS Steering Committee. Through the Steering Committee of the GBV IMS, a number of partners reached out and service providers reached out to ask, how they could continue to provide services. And pretty quickly, we ended up putting together through the GBV IMS Steering Committee and technical team a series of podcasts and videos. Maybe we can put the link in the chat box on some initial guidance on how to keep providing case management remotely through phone-based or hotlines. Following that, and this was essentially based on the IRC guidelines on remote service provision. And following that, a number of actors, including UNICEF, the GBV AoR Helpdesk, and a number of organizations that are part of the steering committee and beyond, came together to put together more extensive guidelines on remote case management. UNICEF felt that there was the need to operationalize these guidelines, and with the generous support of BHA, we put together this training package that hopefully is going to provide some very concrete steps on how to train case managers, social workers on how to provide case management services through hotlines or phone-based case management. So that's a little bit of an introduction. And without further ado, I'll hand over to Virginia Suko, who's really the one who steered the project and the process of putting together this training package. Thank you.
Thanks so much, Caro. Hi, everyone. It's such a pleasure to be here with all of you. My name is Virginia Zuko. I'm a GBV case management specialist with UNICEF, with our GBV and emergencies team based at HQ. And I had the pleasure of working with really a wonderful interagency team for the development of both the guidelines, which you're seeing a picture of on the screen. So these were the COVID-19 guidance on remote GBV services, focusing on phone-based case management and hotlines. And then, as Caro mentioned, going through this process of operationalizing the guidelines, for lack of a better term, to develop this training package. Sarah, maybe can you go back to the slide before, just so I can go over the agenda? I should have put those in a different order. That's my fault. So Caro just set the stage for us a little bit. I'm going to do a quick overview of the training package. I did just put 3 links in the chat. The first link is to the series of short videos and podcasts that Caroline mentioned, which for each 7 specific topics. Then I put the link to the guidelines, which I'm hoping many of you are familiar with. We actually had the opportunity to do a launch for that guidance back in 2021 through the COP. So thanks again, Community of Practice. And then I also put a link to the actual training materials in the chat as well. So I'll do a quick overview of the training package. Then I'm going to hand over to my colleague Dorcas, who will give us a quick highlight on when tech is not an option, and what are some options that we can consider, because as exciting as it is to be able to continue to offer services via phone or operating a hotline, we also know that sometimes connectivity and access to a phone is not a feasible entry point. And then we will hand over to our colleague Jacqueline, who's here from NCA Nigeria, who's going to talk to us a little bit about their lessons learned from providing phone-based services and operating a call center, and their use of the guidelines, the guidance that came out. Next slide, please. And next slide. Thank you. As Caro mentioned, the training package was really an opportunity to sort of operationalize the guidance that already existed. So the training package is based off of that COVID-19 guidance, with the caveat that the goal of the training package is really to not be specific only to COVID-19. What we know is that remote service provision was not born out of COVID, but it did kind of grow exponentially. And it became a modality that was more commonly used in a lot of contexts where access to face-to-face services became more shut down than it was before. So the goal of the training package is to provide materials to build the capacity of caseworkers or frontline service providers that would be providing frontline services via phone or call center operators, to distinguish them from caseworkers that might be operating a hotline, as well as maybe their supervisors. So the goal is for it to be really, really practical, and it does include activities and case studies throughout. Next slide, please, Sarah. So just to touch base on what's in this package and maybe what's not, since it is based on the guideline, the training package primarily approaches 2 different forms of providing services. One is phone-based case management. So this is case management to primarily maybe existing survivors that the organization is working with over the phone, or could include providing services to new clients through direct referrals. And then it also talks about providing services through a hotline, which is going to look quite different from phone-based case management. So it goes into some of the more nuances of what are the priorities when you're operating a hotline, phone manners, how to manage calls, challenging calls, and I'll get a little bit into what content is actually in the modules. Next slide, please. So there are 5 modules. An important consideration is this is not a basic GBV case management training. As many of you on the call hopefully already know, we have released in 2017 our interagency GBV case management guidelines, which include accompanying training materials. So the goal would be that if you're looking at providing remote services, whoever you're training and using this training package for has already been trained on GBV case management. So module 1 does start out, of course, with a little bit of review of GBV core concepts and GBV case management, but it's not a GBV core concepts training or GBV case management training on its own. Ideally, whoever is participating in or using these training materials, they have some baseline knowledge of that information as well. Module 2 dives into considerations, especially if you're transitioning to remote services or starting remote services, but that hasn't been your baseline to date. And then modules 3, 4, and 5 get into sort of the practical aspects. So I want to dive into it a little deeper. So next slide, please, Sarah. I talked about this a little. I talked about modules 1 and 2 a little bit already, but just to show you that basically each module has 1 or 2 PowerPoint slide modules and then accompanying handouts, which complement the practical activities that are included in each module, and then as well as case studies. So we tried to feature case studies from contexts that have experience or didn't have experience, but found themselves needing to transition to remote services. And you'll see here in module 2 is a case study from Nigeria, which is why we're really excited that we have NCA here to talk a little bit about their experience. Module 2 really dives into considerations for revising your standard operating procedures, considerations around technology, safety, resources. So module 2 would actually be a little bit more targeted, maybe at an organization level or a program manager level, to talk about what are things that you really need to think through if you haven't been providing services via phone or a hotline before you dive into that modality. And one key aspect or component of this is that phones are not always a solution, even though they sometimes can be, which is exciting. And so what are some considerations if you are in a particularly low or no tech context? And so when I'm done giving you an overview of the rest of the training package, I'm going to hand over to my colleague Dorcas, who's going to talk to you a little bit more specifically about what's in that video and what paper or resource that video is based off of. Next slide, please. Module 3 dives into phone-based case management. So this would be, it dives into how case management steps maybe transition or what steps you're prioritizing when you're providing case management over the phone. Again, with an existing client, or if you have opened up a call center that's more than just a hotline, so your caseworker is actually taking the time to go through a more, what looks more like a case management process. What are considerations for that? So it goes through the steps of case management, what shifts, what stays the same, what looks different. And then there's a sub-module that's specifically on safety planning over the phone. As we know, safety planning is an integral step to GBV case management and is relevant, yes, for cases of intimate partner violence, but actually beyond that. And so we decided to dedicate some intentional time on how you would walk through a safety planning process with a survivor over the phone. Next slide, please. Module 4 talks specifically about hotlines. So, you know, what is a hotline? What are considerations for operating a hotline? And what does talking to someone who calls into a hotline look like? And how does that differ from phone-based case management? Because that's a really important distinction and nuance. And then module 4 does have 2 sub-modules. One is around managing challenging callers, everything from a very silent call to a crisis urgent call, to when perpetrators call into hotlines or prank calls. So it's all about challenging callers. And then there's a 3rd sub-module on how to handle a caller with suicidal ideation or a suicidal caller. So diving into a little bit the specific challenges and nuances on how to support a caller that is calling in with suicidal thoughts. Next slide, please. And because supervision, staff care, and of course, data management are all also integral parts to case management, Module 5 is not really directed only at supervisors. It is really important for caseworkers as well, but is all around supervision of remote services. It's not specifically to providing supervision remotely. It's more about supervision considerations when you're providing remote services. So the module dives into supervision, how to maybe staff and manage phone-based services, where a service is being provided from, a little bit of nuances around hotlines and shifts and all of that, and includes considerations for staff care, and maybe what are some added considerations to think about, especially around protocols that you're putting into place to ensure that you're thinking about staff care and well-being as part of this transition. And there's a sub-module specifically on documentation and data protection, which specifically talks about, again, when Jacqueline from NCA Nigeria speaks, she's going to talk about how they're operating a call center. But during COVID, we know that many caseworkers were maybe providing some phone-based services from home, which obviously provides different considerations around documentation than if you're working from a more office setting where you're ideally having, locked storage containers to store safely any documentation. So it gets into a little bit of those nuances. I'm going to put the link in the chat one more time. I know that this was a really, really quick overview. I'm sorry to share that for now, the training package is only available in English. If any of you have exciting opportunities to get the training package translated, I'd be really open to hearing about it. So please don't hesitate to let us know. We're hoping to have funding to be able to translate it into more languages in the future. The link that I share, the current training package is in PDF format, but we are working on getting the actual PowerPoints and Word document handouts up there as well. So just be a little patient with us as we get it up. But thank you so much. And I will hand over to Dorcas. Next slide, please. Let me make sure. Yeah, to talk to you a little bit about this important highlight. So Dorcas, over to you.
Thank you, Virginia. What a great resource. And I also want to thank all the other agencies who were also part of putting this together. It's really great to see it come to life. Thank you. So as Virginia said, and as most of you are probably aware during your own experiences during COVID, the mobile phone solutions or hotline solutions are really great. We managed to reach a lot of people we wouldn't otherwise have at the height of the pandemic. But as we were going along, we were hearing from a lot of service providers that they were struggling to reach a lot of women and girls in very difficult circumstances. And it wasn't particularly surprising. If we think about it, we know that there's a gender digital divide. For example, we know some stats say there are almost 443 million women across the world who don't have access to mobile phones, or even if they do, they are not the sole owner of the phone or can't independently use it. And that's on the sort of like survivor or client side, but also with some service providers, doing all of the remote GBV service provision requires a certain digital infrastructure. And a lot of service providers in many contexts just couldn't provide it, particularly local women's rights organizations who may not have access or direct access to strong sources of donor funding. So they weren't able to adapt. they were ingenious in some of the ways in which they found to reach women and girls we wouldn't otherwise be able to reach. So there is a part of the resource that has a video which is 8 minutes long, so it's too long to play here, which goes through some of these ingenious ways in which local women's rights organizations reached out to hard to reach women and girls, and particularly adolescent girls. UNICEF also has a paper that's coming soon because we partnered with the University of Washington in St. Louis to try and track what was happening with service providers in a number of contexts. And we have a digitalization paper that's coming out, which really brings really interesting findings from Iraq, Italy, Guatemala, and Brazil around how some of these digital solutions or digital case management or remote case management, whichever terminology you feel comfortable with, was good on one hand in terms of, as we said, reaching women and girls we wouldn't otherwise have reached, but then also how there were unintended consequences. And I know in the module there is a lot around safety, because we also saw a lot of like digital GBV, as it were, as well. So there's a small but important section of the resource which tries to give many different creative solutions. Some of them are ingenious, some of them are maybe only suitable for that particular context. We heard about local women's rights groups, for example, trying to find ways to know if someone was in danger and then connect them to services. So that was one of the key things. How will you know someone is in danger? So the low and no tech solutions aspects of the resource talks about different ways in which some local women's rights organizations managed to do that, which was drawn from a paper we put together at the height of the pandemic. Some solutions included creative whistling alerts, some included placing certain signs or pieces of cloth outside a household, but they all relied on a level of trust and also the survivors somehow knowing about these, what we call alert systems, and then also the perpetrators not knowing about them. So how these local women's rights organizations found a balance between making sure those who were most at risk knew how to alert for help, but also making sure that awareness wasn't so broad that perpetrators could find out about it. So there are all sorts of ingenious solutions, but it always gives us to mind the need to always know that no matter how well we're getting more digitally connected, a tech solution isn't always best for everyone. So I think Virginia has put some of the links in chat around where you can get more information, but I hope you will find the resource as useful as we did in putting it together. Back to you, Virginia.
Thank you so much, Dorcas. And I did put a link also to the paper that Dorcas referenced in the chat. So have a look at it. So Sarah, please, next slide. And I'm really excited to hand over to Jacqueline, who's here from Norwegian Church Aid Nigeria. So please feel free to introduce yourself, Jacqueline, and let Sarah know when she can move to the next slide.
Thank you so much. Thank you very much, everybody, and Virginia, everybody, for today. I'm representing the voices of field worker in Nigeria, and also I want to appreciate the work that was done in my absence, because there were team members that were able to do a lot for me to be able to present today. Next slide, please. Yeah, so for us to achieve this objective of effectively managing call center activities in Maiduguri, Nigeria, the Norwegian Ministry of Foreign Affairs and the Nigerian Pool Fund were able to implement and fund this project so that we're able to effectively implement the hotline activity during crisis and also post-crisis. And after the phone remote case management, we were able to come up with a free toll line that we normally circulate it to the entire community, mostly in Borno State, so that people are aware and are able to call anytime they are experiencing any form of violence. And as I mentioned, from the onset of setting up the call center, different stakeholders were in engagement. That is the GBV subsector in Nigeria, the UNFPA, and we were working also closely with the Ministry of Women Affairs, so that we're able to have a state-owned call center that can be easily be sustainable in future, and also we are able to give it, the government are able to own it in case NCA, Norwegian Church Aid, is not able to continue in future. So that was the bigger objective for us to have this call center, so that it can be a state-owned program in future. So for the toll-free line and the call center, we are operating an 8-hour toll-free telephone line, and with a total of 10 booths. So already, as I mentioned, the Ministry of Women Affairs were very central to identifying a location where we are able to construct the booths, and also after the construction, we are able to migrate to a different location that was very more flexible and more conducive for us to be operating the call booths. So after that, as I mentioned, we have 10 booths, and every booth have a call center, case worker who is sent there to manage cases and listen to the women and girls that are calling with the GBV cases anytime they call. So we have also an extension of a satellite booth. One of our field locations, that is Bulka, the transit center, we most of the time there's a lot of influxes, and we are not able to manage at the normal women and girls safe spaces. So we have a satellite booth so that we're able to connect any survivor that are coming at the transit center to this call center based in Maiduguri, and the team are able to provide services effectively and timely. Next slide, please. Next slide. Yes, so I think a lot was done during COVID-19, and the COVID-19 pandemic also exposed us to how effectively and flexibly are we to transit quickly when a crisis happened, because it's also as a program, at the program level, we were able to think outside the box and be innovative to ensure that despite of lockdown, despite of not accessing the services and providing the services on time, how can we provide services to women and girls that were really suffering during COVID-19? So in that response, NCA did some specific activity to ensure that we timely respond to the survivors of gender-based violence. One thing that we did, that we constructed a phone booth in our existing women and girls safe spaces. And after the construction, whereby they were equipped with soundproof, and we were able to effectively handle the cases at the field level, we procured tablets. And the tablets were given to the volunteers, and also the case workers based in Maiduguri also have their tablets, and they were able to connect easily with the survivors of gender-based violence, and they're able to respond to their cases. And in doing that, a lot of training was done to the community volunteers on how they can operate. And also the community volunteers, they were not the direct people handling cases, but they were able to support survivors that are accessing the booths to make calls easily and to be supported. And I think one thing that also the COVID-19 also made us realize that it is very important to be able to be prepositioning supplies to help us support survivors that are in need. Despite the lockdown, because the humanitarian aid worker were not able to access the field location, but at the community level, there was easy flexibility. So the beneficiaries and the women and girls were able to go to the women and girls safe spaces. So what we did, that we follow up the COVID-19 protocols, where we ensure that there's a reduced number of people, but because our staff were not able to go to the field location, that is why we were able to use the phone booth conversation and using phone to provide services. And in doing that, one thing that also we did a lot of timely updates of referral pathway. And this we didn't only do as NCA, but we also coordinated with other partners. so that we're able to update and have updated referral. And our focus were more on health facility, because we realized that during that time, the one of the entry point, and as usual, the health were able to provide services despite of the pandemic. A lot of information and awareness was done so that the people in the community, the women and girls, are able to know that despite the lockdown and despite of lack of women and girls safe space activity, they can still be able to report and call somebody to listen to, and also to provide services. Next slide, please. So the next thing we want to discuss is about the call center infrastructure. Immediately we finished the phone remote case management. As I mentioned, there was funding that came in, and we were able to construct the phone booths, the call center booths in identified location that was identified by the Ministry of Women Affairs. So this is more technical, as I can mention that, but I just want to highlight shortly that at our call center, we worked closely with a partner, a technical partner, that is eHealth, to ensure that they set up the infrastructure running during COVID-19, and also to ensure that all necessary equipment were in place so that we are able to easily connect with the beneficiary at the different field location and provide services. So our call centers are powered by solar system that runs continuously, because most of the time, one of the challenges that we had before, there is no electricity, the power is not there. So it was very important for us to have the solar power in place so that the infrastructures and the equipment can keep on going on time. So we have a dedicated telecommunication gadget that we use to ensure that our call centers are receiving calls on time, and any person calling to receive services, we are able to receive timely. And as I mentioned, this is a toll-free line. So any person that is having a phone can call, and they can be supported. And as I mentioned, this is technical. I don't want to go into deep on how it works, because we have a technical person that is doing that. But one thing that I want also to mention is that this call center infrastructure also help us to enhance confidentiality and privacy, because as you are aware, most of the time, women and girls get barriers to access services because of hindrance of cultural and social norms that does not allow women and girls to easily move. But with this call center and toll-free line, any woman who have access to phone, whether theirs or their relative or a neighbor, can easily call and get supported on time. Despite having call center, anything with technology infrastructures have their own challenges, I can mention. So one of the challenges that come in is on the poor connectivity. We need a lot of coordination with the country office, MTN, phone provider, telephone provider. So in case there is any poor connection at the MTN level, it also affects us at our field level. So that is one thing that we have been closely coordinating with relevant stakeholders so that we're able to provide services on time. Thank you. Next slide. So one thing that I would want also to discuss, that in any programming, there's always lesson learned. You know, the COVID-19 brought new norms, and in the new norms, what could have been, could we have done better so that we're able to provide services? So during the service provision, all of us are aware that during COVID-19, there were a lot of cases of gender-based violence, a lot of suffering for women and girls, and also men and boys. But with this call center, we were able to provide timely services for women and girls during COVID-19 and after COVID-19. And because of that, you know, the need to be listened to, the need to be supported. As NCA, we are able to provide that. And as I mentioned, the barrier, the call center also were able to reduce the barrier of movement, because now any person undergoing violence can make a call, and they are supported. And for us to do that, a lot of information dissemination were done. At Nigeria level, we do a lot of radio jingles. So what we do, we develop a message, and then we translate it. We work closely with Translation Without Border to help us translate the messages. And then we identify the radio station to be airing our radio jingles in different languages. So our radio jingles are aired in different languages so that we're able to reach a diverse community, a diverse location. And as many people are getting information on the toll-free line and able to call, the more people are calling and the more services we are providing for our providers. And in that, we have realized that one of the lessons learned is this comfort. Women and girls feel comfortable to report at their convenience. And also for adolescent girls, most of the time, it is an age where they feel not comfortable sharing, but the fact that they have a phone call and they believe you're not seeing their face, and they feel that comfort and to share and also share what they're going through. So that has been a lesson learned, that because of the call center, they are able to be comfortably reach out and be supported. And as in Nigeria, one of the things that we worked with the Minister of Women Affairs, thanks to Madam Falmata, is for us to work on sustainability and empowerment. We coordinated with the Ministry of Women Affairs to be able to identify for us female graduates that have just finished the colleges and have basic education requirement on case management, on social sciences, and can easily manage cases of gender-based violence. So after identification, it was the role for NCA to do the training, capacity build them, and also ensure that their skills are strengthened to be able to handle cases. And in as much as that, we also have very dedicated staff, case workers and case managers that are able to support and also ensure that service delivery is done on time. Next slide, please. The other thing that also we noted during the transitioning and also the COVID period and post-COVID period, there has been a lot of acceptance. This feedback came through the call center and also volunteers at different field locations, where the women and girls gave feedback that they many a times prefer remote case management, and because they feel comfortable, they can disclose easily to case workers that are providing services. And this also help us to understand that most of the time the barriers that we have because of long distances, women and girls and beneficiary walking from a very long distance to seek services is also an aspect of reducing risk and also promoting safety and well-being for women and girls. So in doing that, a lot of referrals and service provision has been done. But one of the lessons learned that we have realized that, when you're doing referrals, when a call center caseworker is handling cases in a normal setup of a static case management center, it is easy to do referral because you are very conversant with the locality, with the different stakeholders in place, and how you can easily connect or maybe just meet during coordination, and referral is very easy. But during in the call center approach, we have updated referral thanks to the coordination with the GBV subsector. But most of the time we have it, we just need to make a call, and the call center caseworker might not be very conversant where the locality is, because one thing that came out, when a survivor is asked whether they know maybe a health facility in their location, they might say they don't know. So we just ask them to just ask around to go to the nearest health facility. This is for the survivors of sexual violence so that they can get supported. Unlike in the static where you can easily give direction for the survivor, and also in other aspects they can be also escorted so that they can get supported. And sometimes when you're doing referrals, it's very difficult for you to know whether the survivor was able to go to the next referral point or they were not able. So, these are some of the challenges that we face in referral and also service delivery, because we depend on other organizations working closely with us to be providing these services apart from the psychosocial support that we are providing as NCA. One of the things that I think has worked in Nigeria so much is the language diversity. In call center, we are reaching diverse community, and in Nigeria, there are at least 4 languages that they are communicated in the community. So because we have call center volunteers in different booths, so assume a survivor that speaks Kanuri calls, and the first person call center to caseworker to receive is a person speaking Hausa, they're able to connect that survivor to the person who can speak effectively with them. So that the language barrier we are able to manage that, and also make a survivor feel, the rapport is created easily when somebody speaks your language. One thing that we've learned, and also in the training documents, we have realized that many a times our caseworkers get calls from the insurgency, insulting them, asking them why they're interfering with normal cultural beliefs, and in such sometimes it's very threatening, because the mentality when you get a call from insurgency, you feel fearful. But one thing that we have put in place as Nigeria is to ensure that our caseworker have code. If not coded, they use their first language, and in the context, first language, the entire community might have the same language name, I mean. So that has been able to reduce the risk. But because of this insurgency call every other time, I think in the guideline, there's aspects on how to respond threatening calls. But in this situation, the threatening call is from insurgency that has been the cause of all these crises in the locality. So sometimes it's very difficult. So what we do as a program, as an NCA, we do a lot of quarterly supervision and debriefing, whereby we are able to hire a very qualified consultant to be able to provide supervision, and the staff are able to categorize and heal and recover, so that they can better provide services to our beneficiary. The next slide, please. I just want to mention some of the challenges during call center operation with our caseworker. Most of the time there is poor network. Anytime there is poor network and maybe the survivor is calling, you will experience call drop. And when there's a call drop, then they call back, they might not get the same caseworker that was handling their case. And again, when there's extreme poor connection, then it means that we're not able to receive calls on time. And the fact that we are doing audio case management, we rely on verbal communication. Unlike the normal face-to-face case management, you are able to assess easily the vulnerability, the extent of torture, and the need. So we rely primarily on verbal communication, and most of the time they find it very difficult. I hope I'm not going beyond the time, so that they're able to find it some difficult to create rapport. Sometimes, as they mentioned, sometimes you get survivors, they want to talk long during the introduction. Some come to the point and tell you what they want. Some, they don't want, they just want services. All these things are very dynamic, and it can pose challenges for the caseworker, and also challenges to the beneficiary, for women and girls that are accessing services, because when there's dropout, if a person or a survivor had a critical need, then it's very difficult for them to be supported. But again, we do a lot of coordination at the field level to see that anytime they are supported. Case follow-up is very difficult. In Nigeria, in Maiduguri, we have a one-stop center that has been very, very critical in ensuring that we easily refer cases and we can easily follow up at as a service provider level. But most of the time, following up a case because they call and they might not call again, it poses a lot of challenges for the caseworker. But sometimes one of the voices that we had during COVID-19 until now, sometimes when they've created rapport, the survivor can call and mention, I want so and so to the person that has been listening to my case to continue with my case. But you know, those are just very few incidences that we get. As I mentioned, caseworker constantly receive threatening calls from the insurgent, and we have been able to mitigate that, but you know, we can't control that, because the more we air the messaging, the more, in fact, everybody is able to call. So we cannot mitigate, we cannot avoid that, but we can come up with mitigative measures so that we're able to reduce it and also support our staff so that they are able to avoid vicarious stress and be able to be supported easily. The last and the not least is doing referrals. Some actors are not on the ground. Even after post-COVID-19, sometimes you refer for specific services and maybe they go to the point of referral and the services are not there. But one of the things that has been very effective is at the GBV sector level, supported by UNFP, I think one of the things that we have done in Nigeria is mapping out what services that partners are providing and whether they have all these services in place, so that when you are referring to the point of reference, you are sure, the caseworker is sure that this service is there or it's not there. But many a times services are not there. I think that is the general gap in GBV programming. So that is all from Nigeria. Thank you so much for listening, and back to Sarah and Virginia. Thank you so much.
Thank you so much, Jacqueline. That was super interesting. And there's a lot of questions on the chat. So I'm going to stop sharing the PowerPoint and invite the panelists to turn on their camera so that everyone can see you. And the first question comes to you, Jacqueline, unsurprisingly, since everyone was super interested in your project. One of the questions was how much does this call center program cost? Can you share the idea for other people who might be interested in trying to do this?
Should I respond immediately?
Yes, why not? We have 15 minutes. You presented the perfect amount of time, so.
I think what I can say is it depends on what you want, because I might not give a bigger quotation because maybe you want to reach a less coverage, but a lot of cost goes to setting up infrastructure. That is where a lot of cost goes to. And also it depends on every country. Because one of the things that we do in infrastructure, we have the toll-free and everything subscription is done on a yearly basis. That is not very, very costly, but the cost is more on putting the infrastructure in place. So I may not know the exact amount, but I think one of the things that they can do is to identify to what extent do they want, and what services, what do we call them? The phone providers, the telephone providers, what do they provide? Because each country have their differences. But much of the cost goes for the infrastructure and radio jingles, because now we have to continually air our messages so that people can call and be supported.
Another question that a lot of people are quite interested in the chat is about the supporting of the caseworkers. I think everyone was a bit worried about when you were talking about the insurgents and Boko Haram calling and making threats. So people are interested in knowing about how you support them and how do you manage the threats. Like, can you just go a little bit more in depth about the supervision systems that you had in place?
Yes, so one thing that we do is we have, for the call center, we have a stationed case management officer that is working closely with the caseworker, so that anytime there is any cases of insurgency call, they are supported. But again, despite of that, there's also the case, the vicarious trauma base, because of you are listening to the survivors. So what we do a weekly supervision, whereby you provide a platform to the case management officer, provide a platform to listen to the caseworker who has a need. So the weekly supervision is done. Yes, so and again, one thing when we do, as I mentioned, because we provide an open platform for the caseworker to easily share anything that is affecting them. So if it is calling from the Boko Haram, we have been able to discuss with them that they are not, as caseworker, one of the things I wanted them to know is they are supporting women and girls. And many women and girls have gone through violence. So in as much they get insult, they need to know that at a personal level, the services they are providing is supporting many women and girls than only one caller that is calling them and threatening them. So, just talking the real thing that happens. The other thing that we talk to them, because is a caller complaining and insulting, you just come up, one of the caseworker, if I may say, there was a call and they were saying, I'm sorry, sir. And then after finishing that, she told the insurgent, but in case you get a woman and girl that is facing violence, kindly give them that toll-free line. And the person does hanged, and it ended. Sometimes you balance and you realize that you win at the same time. So I think that was very important. And the other thing is just quarterly now supervision, where the psychologists are able to assess to what extent, because sometimes we get people that now need a lot of support apart from the PSS and listen. I hope I've answered that.
I think that was great. There was one more question as well on there about, were you doing outgoing calls to people who had contacted the case management? And what was your strategy in case you reached the perpetrator?
Yeah, so yeah, we are doing in calling that we depend the system that we have, the survivor callers. So that I think that also has reduced the chances of perpetrators calling, but there are incidences where you get in the process of survivor calling, the perpetrators come in. And that is why when it goes back to the first introduction, you tell the survivor, in case you feel that you're not comfortable, hang and then you call later. So the fact that we depend on the survivors calling, it has reduced the risk that is associated of a caseworker calling the survivor and maybe getting a perpetrator. I think that is the risk that has been managed. But also we have a team here, maybe if they have additional thing to add, but that is what we do at Nigeria level.
Okay, are you asking if a member of your team would like to unmute and say a few words? That's
yes,
fine with me.
Yagana or Charity, if you are online, maybe you can add.
Yeah.
Or any caseworker. I know they are online.
Yes, I have a question, but I couldn't raise my hand. Sorry.
Oh, no, sorry. Just we're letting the caseworkers who work with Jacqueline unmute themselves to say a few words. If you have a question, please put it in the chat, and we're finishing in a few minutes.
The team, don't be shy. Don't put on your video because we want to hear your voices. So anybody, Yagana.
Okay, well, maybe while they're getting their nerve up to respond, I'll ask Virginia. There was a question for you. Who is the actual intended audience for the training? Is it only for those who are staffing the hotlines, or does it manage the whole team?
Yeah, thank you so much, Sarah. The overall training package is very much geared towards caseworkers, hotline operators, and supervisors of either hotline operators and caseworkers. I touched on it a little bit, but probably too briefly. Module 2 is the one module that is a little bit more directed at maybe a program management level staff or at an organization level around considerations if you are looking to set up remote services or a call center like NCA did, and some considerations around what you need to have in place, considerations for consultations around what the best way to implement it would be, and then also considerations for how to adapt your standard operating procedures and other policies that would be really relevant to this setup. So the training package would work for both whether you're already operating a call center. I mean, it could still be used to train new caseworkers or new hotline operators that you're hiring. So it's not specific to whether you have or don't already have remote services, but modules 1, 3, 4, and 5 are really for that frontline staff and their supervisors. And then module 2 would be a little bit more relevant for, again, whoever's going to be involved in that setup, which sometimes is a little bit more at a program management level. And then Sarah, just since I'm already unmuted, Jacqueline, I know you were hoping to put some of your staff on the spot, but maybe to share a little bit, one of the case studies that's featured in the training package is from Lebanon. And I just wanted to share that they were doing some calling back. UNICEF was working through partners, obviously, but some of the partners were doing some calling back of survivors, but only when the survivor had first reached out and there was an agreement that it was safe to call back. And there were stipulations put around that, like maybe specific times of when it would be safe to call back. And then most importantly, protocols were put in place in consultation with the survivor on what to do if somebody other than that individual answered the phone. So this was during COVID-19. So in Lebanon, what they were doing is saying that they were calling just to share health wellness information around, COVID-19 related information that would be relevant in Lebanon. So just to think through the fact that I think that there are some contexts that have adopted the practice of calling back, but there are really important safety considerations, which the person that asked the question brought up around making sure that you're not just blanket calling people back, and that if a survivor asks for a callback, you need to make sure that you're thinking through those safety considerations and coming up with a very specific plan that would not put the survivor at further risk.
Thanks for that, Virginia. There's one last question, and I'm sorry we won't be able to get to everyone's questions in the chat, but we will send everyone the PowerPoints and the documents, and we hope that you'll go through them and reach out. So this one was about your program again, Jacqueline. Was there a feedback and accountability mechanism tied to the program?
Yeah, I think that is a very good question. One thing that we have done is we have aligned it with our normal CMR complaint mechanism, so that survivors and any person who wants to complain is able to complain. But one thing that we have been thinking of, I think that is one of the discussions that we've been having with UNFPA on if possibility we can have it as integrated in the call center, whereby if there's a complaint, we're able to map out what are issues coming up. Because if we align it with the normal CMR, sometimes I confuse CMR and CRM because I'm also in clinical management of REM. So one thing that we in as much we have the feedback mechanism in place, but most of the time, we get now the normal programming. So the normal programming, complaint and feedback are also managed with the dedicated team. But I think one of the things that we are thinking of on how can we integrate the response and mechanism feedback so that we're able to timely respond to the needs and issues that are coming relating to the call center. So if that would be there, I think that system.
Oh, I think that as we were muting the person who jumped on, we accidentally muted you, Jacqueline, so you can unmute yourself and finish. But we are out of time, so I wanted to thank everyone and turn it over to Virginia to give a shout out to all of our partners who worked with this, and thank all of the participants and the panelists for a really fascinating webinar. Virginia.
Thank you. I mean, first and foremost, just a huge thank you to Jacqueline and NCA, as well as Dorcas and Caroline for helping us launch this resource and for sharing their wonderful words. Again, a major shout out to the Bureau of Humanitarian Assistance for funding this project and making this package possible. And then just to reiterate, this really was an interagency effort. It wasn't only UNICEF. The GBV IMS Steering Committee member organizations, so UNFPA, UNHCR, International Medical Corps, and International Rescue Committee, as well as Norwegian Church Aid, of course, Trocaire, and then Plan International was also involved in the development of the guidance. So just to say that there were so many people that were involved, as well as the GBV AoR Helpdesk, which I know, Sarah, you'd love to put that plug since it's a wonderful resource. So just to, and the GBV AoR, of course. So just wanted to shout out, this was a very interagency effort, and I hope the training package is practical and useful to many of you wherever you're calling in from.
Thanks again, everyone. We'll see you on the GBV AoR Community of Practice, and please feel free to download all these links and start training. Take care. Thank you.
Thank you.